we start our challenging session after lunch, which is always the session where the speaker have to be very engaging to keep us all awake. I'm Daniela Moșoiu. I'm from Romania. I'm a physician, and I'm also part of the EAPC board, which Professor Larkin is leading. And in this afternoon, we will introduce the topic palliative care everywhere, which I think is very closely linked with the theme of our conference. And we will have the chance, I think we heard about from David about focus and locus. Locus, that's what you were talking. So we will hear in different regions what is the focus of palliative care and how is it really locally developed. We will start with Europe, with Professor, first I want to also give the chance to my colleague, Professor Ashkopal, who has recently, in January, been honored by the government for his activity in palliative care, and he has been receiving an honorific degree, so congratulations, Professor Ashkopal.
Thank you, thank you.
Who's co-chairing this session. Please introduce yourself. Yeah. Our first speaker will be Professor Larkin. He is the president of the EAPC, and he has the very challenging role in EAPC to integrate East and West and different stages of development of palliative care, and he will talk about integration of palliative care in Europe. It is.
That's better. So, buon pomeriggio. Grazie per la possibilità di parlare oggi. Thank you for the invitation. I'm asked to speak on two things. When I was listening to my colleagues this morning, I was ticking off saying, oh good, I haven't got to talk about that. I haven't got to talk about that. And then I had to think about palliative care in Europe, because what do we mean by Europe? And I think part of my discussion today is that in as much as Europe is one entity at a political level, perhaps, we are in fact an accumulation of languages, cultures, beliefs, ideas, and somehow we have to work together as an entity, and it's a very important message for palliative care. So I'd like to talk a little bit about some of the contextual issues in European palliative care, why integration is important, and particularly now. What are the opportunities and challenges that we have? What are some of the questions that it raises for us? And then perhaps to finish off, I want to talk about the wisdom of some of our elders, the people who have led us to the point that we are at now, and what are the messages that they give us for palliative care for the future. So we know that palliative care has a changing focus, and from the WHO resolution, we are very clear that the public health message is extremely important, and there has been significant work done in all the countries I visit in my role as the president to see how we can strengthen palliative care within the existing health system. At the same time, in Europe, it is very important that we remember that because of the people we serve, the patients and their families, we must remain clear about our need to have clinical excellence, good management of care, and to bring together the whole team to provide that care, so that as part of the public health issue, we retain what is important in palliative care as we go forward. There has been a lot of developments, and of course my colleague Professor Centeno is here, and Professor Clark, who are leading on much of the global understanding of palliative care. And we have developed in the EAPC the Atlas for Palliative Care, which has been really important, and I cannot overemphasize how important that has been to help countries understand how they develop palliative care in their country, What are the key components that they need? What is it that they need to do? But we also have some very good documents through the WHO which give us clear indicators of what good practice is. For example, the solid facts, the document Better Palliative Care for Older People. In a way, we don't need too many more documents, but what we do need is how do we implement those to improve the care that we actually have for our citizens in Europe. So why might that be important? Well, there are many, many documents that have looked at this, but we know, and this is an accumulation, so I'm not referring to one particular paper here, but we know that approximately 75% of our European citizens would benefit from a palliative care intervention. And many of those are older people who have multi-morbid disease, and I'll talk about that in a moment. We know that 50 to 70% of people in nursing homes need palliative care, and certainly again in my visits across the EU, I see more and more palliative care being developed in the nursing home and residential care setting. But we also know that people who need palliative care often are the cause of 70% of the costs in the last 6 months of life. And there are more and better economic studies that are saying this is one of the benefits of the early integration of palliative care. If we can embed palliative care as part of a system, then we have the potential to reduce the overall costs. But for the patient, the inappropriateness of a hospital admission at end of life, which is really nothing that anybody, I think, in this audience would want to see. We know there are very good papers, and I'm talking about the paper of Tom Lynch here, that makes it very clear that, and this obviously there's a new document coming out that Professor Clark mentioned, but we know that many countries still have no palliative care access at all. However, I do want to make the point, and I use my own country because I don't want to be critical of other countries, that even within Europe, and even in countries like mine, where palliative care is well developed and well on the way to good integration, we still have problems. We still, in my country, have problems where there are parts of the country which are rurally isolated, so people don't have easy access to a GP or easy access to a community nursing service. We have parts of my country where there are no inpatient beds for palliative care, but if you look at the system, it will say to you that Ireland is a good country. And in all the countries in Europe, they equally have their challenges. So inasmuch as we recognise that we have to work to support all the countries of the world, we cannot forget that Europe has its own challenges in the delivery of palliative care. One of the other issues that's come up, and this is a paper that was done in Ireland again, but it makes the point that we are still predominantly cancer-focused. We aspire to the idea of the wider context of palliative care for people irrespective of their disease. But if you look at services, we still tend to focus towards cancer. We need to question that. And the other issue I want to say, people have already spoken about generalist and specialist populations, but the other issue I want to talk about is what we call the rise of the commodification of care. And what that means simply is that health is bought and sold. And this has a particular challenge for the way in which we provide care. The majority of health and social caregivers in the countries that I see are often migrant workers who come to those countries because they seek opportunity for employment. And they are often placed in difficult positions in terms of providing care, often with limited training and limited language skills. And this is something that I'm seeing more and more, even in my own country. So the reality is we need health and social care to support the delivery of good palliative care, but there are challenges that we need to be aware of, and I'll talk about that towards the end of my presentation. We know about the elder care challenge, and we see that in many, many different countries. What does that mean for palliative care? Well, it certainly means that we need to think very carefully around the idea of how we integrate with other disciplines, particularly geriatric medicine, and how we bring together that health and social care perspective to provide good care for all our citizens, because we are all growing older. So what I would say is that there are clearly strengths in the messages that we're getting in Europe. We know palliative care can help to reduce admissions. We know that we are now seeing certainly the rise of a primary care agenda. And certainly where palliative care is delivered well, it promotes a judicious delivery of care. But there are other challenges, and that's where the system fails to see the value of integration, where they don't really see what that will do, and we become siloed into our disciplines. Others have spoken about that. And particularly, again, people have said, this confusion in the language of what describes who we are and what we do as palliative care. There has been work done on this, and the reality is, and I won't dwell because I know others have spoken on this, but we need to be very clear about what palliative care is and is not. Every country in Europe has a slightly different understanding, I think, of not just what the term means, but how it is applied. And we have supportive care and terminal care and palliative care. And all these things have different meanings when you translate them into different languages. So when we come to a table to discuss at a European level what we want to do, are we all speaking the same language? In effect, what I believe we need is almost a glossary which will clarify some level of understanding about what these wider contexts mean for palliative care. So why is integration important? Well, we have a debate about when palliative care should be initiated, and we've got very good studies that say early integration is better. What we do know is that we're very clear now in our languaging that palliative care and active treatment are not necessarily contradictory. And when it's introduced may vary and may be a healthcare system issue. But the point is, it's important that we think about it. So our EAPC message is very much about, please think about the benefit of early integration with the people that you care for. And that means talking to other people and listening to what they have to say. What does it actually mean if you get it right? Well, I think on the left is probably where we came from and the change we're going to. And I've highlighted just two areas here. In the past, we talked about curative versus palliative. Today, we need to have a language that talks about shared and combined care together, irrespective of what your disease is or indeed your prognosis. And whereas we talked about patient and family as the care recipient, what we need to talk about now is patient and family as the care planner, so that we are not telling other people. Someone spoke earlier about people being informed. We are working together to find the best solution for the patient and family in this complex situation. In Europe, there have been some programs to look at this. The INSUP-C study was a study that was supported by EAPC that looked at how do you have best practice for integrated palliative care. And it was across a number of countries. There is a publication, it's highlighted at the bottom of this. And I think what's important is that they highlighted that you need three things. You need an optimization of the organization, the people that lead. You need good care networks, health and social care networks. And you need to have good treatment pathways. So people need to know that the quality of the clinical care they get is vital. But for me, what's most important is the block in the middle that's on its side, which says local characteristics, because we need to apply this to the local need. What happens in one country can be very different to another. And in a country where you have no borders and people may be choosing or opting for care if they live on a border, they may have to look at different models because a country may have a different system. So it's complex, but this program showed that it's possible. This is their definition of integrated care, one which brings together all the groups that are necessary to realize a continuity of care across that lifespan from living to dying. That the dying process, when it happens, is well supported, but more so that it's in collaboration. Collaboration is the key. And they make a very good point about the paid and unpaid caregivers, a point I made earlier in relation to the commodification of care. So why is it important? These are a couple of their publications. Well, integrated care sees the value in a matrix of involved persons. You bring people together. We're a little bit like a diamond. So each part of the diamond shines at a different time, depending on your particular clinical background. And that will help to frame the care, the holistic care that we speak to. The person can make decisions for themselves, and our job is to help them to feel sure that the decision that they make is the right one. From a European perspective, given that each country has its own lifeblood, It's important we value the context of the communitas, a community that lives together. And how do we support that community to care for and be with a member of their community who is coming to the end of their life? But also, and I'll speak about this towards the end of my presentation, it considers the wider political and social dimensions that impact on living and dying. And I think that is a very important thing that we need to consider as we go along in our palliative care practice in Europe, issues of equity and issues of justice. So this is just a model. We've seen many different models, but clearly what they're talking about is flexible, shared, and cooperative care, which is about complexity, and we talk more and more about complexity. The complexity sometimes is how we come together as a group to talk about how we manage this care well. So the key messages, I think, for integrated care is it's actually a hugely important message about transformation. If you take it from where the WHO have positioned palliative care as public health, this integrated model fits very well within that. We need to change hearts and minds, and that's also at the political level. How do we engage with our politicians to get them to understand why this is important? It values the equality and respects persons. It integrates palliative care to speak to the reality of living and dying in society. In some ways, we need to remind ourselves that palliative care is about living until you die. So we need to focus well on the living as well as the practice of care for the dying. And it takes one small step. That's all the INSUPC project looked for, one small step in each country that would help to transform integrated care. So where are the challenges and opportunities? Well, in many ways, palliative care was a new vision, if you like, to alleviate suffering. And bearing in mind that we have Professor Clark here, who's an eminent scholar in this field, we are very well aware that Cicely Saunders had one woman's vision who changed the world. It changed the world for all of us because we're all here. It was underpinned by a strong spiritual discernment. And I think that's a very important fact that we should never lose sight of. The spiritual context of Cicely Saunders' vision is vital to the energy that we bring to palliative care. We should know what that was in order to explain it to others. And of course, it evoked a global movement. That global movement is affecting us in Europe. You will all be aware of the migration issues, the refugees coming, and I take a point here. One of my colleagues in Munich, Dr. Monika Führer, who's a professor of children's palliative care, told me about going to the station in Munich when the refugees came and finding children with life-limiting needs on the platform of the station and trying to find beds for them in hospitals in Germany. That's a very good example of compassionate care in action. But that is the reality that we face with more and more people coming. And although it may not be in the media, the refugee reality is still there. Only last week, we had a number of Syrian refugees arrive in Ireland into a direct provision centre in a part of the country that's quite isolated. I won't get into the political arguments of the problems of that, but it's something we need to remember. I'm not showing you this image because I want to shock you. But I want you to think of the reality that I've heard it mentioned today about palliative care as a human right. But this picture actually tells you what it is that we do in palliative care every day. We witness the suffering of another person. The soldier is moved to do something. He moves to this child. He picks the child up and moves the child to a place of safety. And in every action we do in palliative care, we witness the suffering, we act on that, and we provide a place of safety. And if we can remember that, irrespective of your language, your culture, or where you come from, it's a very clear message to say what it is that we offer in palliative care that is fundamentally different, perhaps, to other aspects. Now, there has been a discourse quite recently that maybe we've written a lot about human rights in palliative care, but there has been one or two papers, and I cite this one by Timothy Kirk from the US, who's questioning, is it enough to talk about palliative care as a human right? Because the argument is that sometimes the idea of a human right only focuses on the individual, when in fact responsibility may be for the collective, the society. And the question is, who is ultimately responsible to ensure that human rights are upheld at the local level? And really this is about an issue of equity, and I know other people have spoken about this idea of systems of where we have disease-modifying therapy for the rich, and Jim talked about this, palliative care for the poor. And I try to use this Irish concept we have called the Anam Cara. It means literally in English, your soul friend. How do we develop the idea of managing the soul within the organization and the system to help us to provide better palliative care so that we do literally believe that it's palliative care for all? And some of that, I think, is about looking at a social justice perspective. That's the idea of looking beyond some of the minute details to consider, well, what is it like for people to live in their society? How far do they have the option for respect and recognition? What are the resources there if people live in poverty? Can they access the system that they need? I like the idea of love, care, and solidarity because in my country, if you wish to care for your family at home, then it's the family that will provide the care because our primary care services are not strong. And so if I want the home care, I need to know if the family are there to do that. That's an issue of public attention to private matters, and that can be a challenge. But the biggest challenge that we have, both for us as practitioners and deliverers of services, are the power relations. How do we understand how our political systems think that will enable us across the EU to develop good palliative care? I also want to make a comment, if I may, about issues of workforce, because this is a particular challenge I see as I do my work in the EU. So I'm going to apologise now here, because I'm sure the people in the audience saying, why has he not got my picture up there? I just want to make a point, and the question is, where are the workforce for the future generation, and how are we training them? We have a big problem still in Europe about the training of clinicians in palliative care. There are many attempts to do this, and certainly colleagues I know on the EAPC have worked really hard to embed education into medical education, standard medical education, nursing education. But the reality is, the pioneers, the people who set this up, where are the next generation? Where are the people to take forward the things that we fundamentally believed in for palliative care? And on the left of this screen, I'm giving you figures from my country about people who are leaving. In the last 5 years, nearly 2,000 nurses left Ireland, 720 doctors, 10,000 applications to allow them to practice in another country. Now, we are a country of emigration, but the reality is I see this migration across the EU, and if people with skills leave an area where they are desperately needed to go to a better job or a better salary, what does it mean for the country that's left behind? That they can't develop their service because they lose their resource. We need to think about that. So what are the key messages? Well, I think the context and practice of palliative care is changing. And I think we continue to work in partnership, and we need to do that. The idea of working together is better than working against. We need to find better ways to do that. The work we do with the dying is extremely important, and we should never forget that. Even though we talk about early integration, care of dying people is fundamentally a part of what we do, but it's not all of what we do. We do many, many other things across the trajectory of life and death. And we know from the evidence that patient outcomes improve when collaboration is the driver of care. So we need to find ways to overcome our different boundaries and barriers and to find ways to work better together. We know how many people in the world need palliative care, but I want to make reference to this particular report, not because of the report, because it was done in the United Kingdom around particular issues, but I want to make the point that Claire Henry makes at the bottom of this. We have one chance to get end-of-life care right for an individual, and at present, this chance is sadly being missed on too many occasions. And sometimes that's because of the system, not because of our goodwill. And so we need to make sure that we get it right every time, in every case. And that's because this meta-analysis of what matters most to patients in terms of good care, I think if you look at that, there's nothing there that will surprise you. But I think the one at the end is important. Well-coordinated and well-integrated care with a continuity of provision, where there is no fragmentation, where people clearly understand who we are and what we do, and where they're not having to continually tell the same story to different people, because when the story is told many times, sometimes we lose the sense of what the holistic bigger picture is. And my final thought is I'm going back to the Irish language. This was said by the President of Ireland when the Queen of England came, and in a country now where we wonder what the future will hold for us with Brexit and borders and no borders. It's a very important phrase because it tells us that we live in the shadow of each other. In Europe, that is very important. We cannot survive without each other. Palliative care in Europe will not survive unless we are working well together. And in a way, that's what we try to do as the EAPC, to find ways so that we understand we live in the shadow of each other. And my final point is I want to refer to the work of Henri Nouwen. Many of you will know him, a Catholic theologian, who wrote a beautiful little book on compassion, a reflection on Christian life. And one of the phrases he says in that is, "You are the difference you make." You are the difference you make. And the point about that is that in the small things that you do every day in your practice, in your work, in your support, you have the opportunity to develop an integrated and better palliative care for all our citizens. Thank you very much.
Thank you very much for this very inspirational talk and motivation. I just want to remember that to the audience that if you have questions, please write them down. We will have at the end of, after the break, at the end of the session, we will have time for discussion. So we will collect then the questions. We will move further. To introduce the next one? No? We will move to our next speaker. He's the